Hello and welcome to another Pipe of Pearl. Today's Pearl, we're going to look at anorectal disorders. So let's try to be as mature as we can and discuss how we can help our patients with quite a sensitive and uncomfortable conditions. So as a means of introduction, when we talk about anorectal disorders, we're obviously talking about conditions that affect the rectum and the anus. We'll have a look at the anatomy in just a bit. These complaints are quite common because it's quite a large collection of different disorders, and some of the symptoms can be caused by multiple different origins. So we'll go into a little bit more detail about those symptoms and how our questioning and our observations can help narrow down the treatment to assure our patient and best manage our patient if we need to. So because of the nature of the disorder, it's quite a difficult minefield to navigate. It's very embarrassing for the patient. Some of the stories can be humorous, shocking, unbelievable at times, but they can also be quite traumatic. So as a clinician, it's our job, obviously, to listen to the patient and also offer consultation in a judgment-free environment. People will get up to all sorts of different things in their spare time, and it's our job purely to treat the manifestations of those decisions. So that's what we will try to do. As far as all the disorders go, they can be clumped into certain categories. Now, these categories will overlap quite dramatically in some cases, but a patient will often come complaining of pain, lumps, discharge, including bleeding, and also itchiness or pruritus. Now, luckily for us, certain conditions fit nicely into those categories, and there's certain questions and observation techniques you can do in order to enhance your understanding of each of those particular areas. So before we get into the specifics of the disorders, we'll have a look at the anatomy. So the rectum itself is quite small, and the anal rectal area consists of everything after the sigmoid arch, basically. And it's broken up into two distinct areas, and they're separated by something known as a dentate line. The lining of the anal rectal region is actually an extension of the skin, especially in the area underneath the dentate line. Above that line, it's normal bowel. It's bowel-type tissue, and it is subject to the same sort of conditions that you'll find in the bowel, just different associations with pressure and often irritation as well. Lining the surroundings of that dentate line is a series of crypts or glands and exit points that help lubricate the actual fecal matter to help prevent tears and to help evacuation more smoothly. Unfortunately, these anal crypts are subject to inflammation and infection and can lead to abscesses, which we'll look at in a little bit. Around the areas to help with the vascular supply of the tissue in order to maintain the mucosa and to keep up the fluid to this anal crypt's glands is a series of plexus. And these plexuses are called hemorrhoidal plexus. So it's no surprise what these plexus, denoted by the blue, actually become if they become a disorder. Surrounding the anus itself is a series and layers of muscles. We have a huge amount of external muscles. We obviously have the muscles around the bowel aspect of the rectum, and then we have both an internal sphincter, that is a circular ring sphincter, and then we also have an external anal sphincter as well. Now, this is designed to keep everything in until it's a point for evacuation. Now, anatomy speaking, the anal rectal region is designed for an evacuation portal, not an entry portal. Unfortunately, that sometimes gets lost in translation, which can lead to a number of disorders and complications that we'll look into. The neural network surrounding the anorectal area is also complex, and you have a conversion of a bunch of different nerve tissue, which are actually incredibly sensitive to pain, pressure, and also pleasure. Hence why diagnosis of anal pain can be quite difficult to pinpoint, because you have a lot of overlap with your irritation, with your pleasure centers, with your pressure, your baroreceptors, and also your nociceptors, all concentrated into quite a small area. So moving on and having a closer look at the disorders, we'll just touch on a few as they're broken up based on those key complaints that we get. Now, I won't go into a significant amount of detail in this lesson, but I do intend on doing separate lessons that will look at each pathological state, each disorder, breaking down the true pathophysiology and individual management of it, if you want to go a little bit deeper in the future. So looking at the things that fit under pain, the most common finding you'll have is what's known as an anal fissure. An anal fissure is caused by irritation quite often, things like constipation or external trauma, that sort of thing. And it is a tear in the anus itself. So in that area that's underneath that donate line is the most common place that you'll get an anal fissure. But you can also get it on the exterior aspect of that external sphincter. It can be a tear, quite bleeding or scar tissue that you'll see, looks a little bit like a skin tag. That can occur there. Now, the way it's broken up is acute anal fissures are anything less than 3 months old. Chronic ones are anything greater than 3 months. Now, these can be quite benign, can be quite irritating, but they can also be quite debilitating and have a particular pain profile that we will look into. The most common complaint people will have with an anal fissure is either pain on defecation, or they'll notice that as they wipe with toilet paper, they'll notice spotting blood on it. And that's the characteristics of an anal fissure. A perianal hematoma can sometimes be denoted as a lump, because the best way to describe it is a blood blister on your anus. Okay, so it's a pocket of blood that fills on your anus. The good news is this is often known as a 5-day disorder. So if someone comes to you with a hematoma and it's 1 day old, it can usually just get treated with a little bit of extrication, needle, local anesthetic, that sort of thing. If it's anywhere between 1 day and 5 days old, then it involves lancing it, removing all that clotted blood, but still quite easy to manage. And then anything over 6 days, it's often a choice where you leave it and the body absorbs it itself, unless of course it's causing significant pain. These ones are quite benign, very rare to get infected or anything like that, but obviously post-lancing and injection can be subject to infection. Ones to really, really look out for, as in massive red flags, are your abscess. So your perianal abscess is a result of substance getting into those anal crypts and causing an infection and inflammation, creating this perianal abscess to form. Biggest sign you will see there is actually inflammation on the exterior aspect of the buttocks. So there'll be red spots on the buttocks, a large one, almost looks like a corky at some times without the bruise, okay? Now the other ones, polylinal sinus or abscess, is quite characteristic as well. That's where an abscess will form in the sacral region. So it's usually about 6 centimeters above the actual rectum itself towards the back, and it has this reddening effect. And this is caused by hair actually being turned inwards and then starting to grow into this sinus cavity, creating an abscess. Can be quite painful, often needs surgery to be fixed, and then long-term management thereafter for quite a difficult wound. It's incredibly common in hairy men and hairy men that do a lot of sitting. So truck drivers are a classic candidate for a polylinal sinus to form. When we look at the last one, our proctalgia fugax, this one I don't expect you to diagnose, because it's actually a diagnosis of exclusion, and it's a particular phenomenon where people will get a random onset of pain that can last anywhere from 90 seconds up to 30 minutes, and it is high, intense pain. It often wakes people up in their sleep, but there's no associated symptoms thereafter. So Often people will come in complaining of rectal pain. They'll go through a series of investigations and there won't actually be a cause, but it continues to happen over and over and over again. And that's where your proctalgia fugax diagnosis comes in, and it's managed. Well, a lot of time it's just ignored. I'm not going to lie. Sometimes they trial some medications like GTN and salbutamol, believe it or not, to help alleviate the spasms. Okay, but they're your clump of pain. When we move on to lumps, lumps can be a little bit easier because you can either see a skin tag, you can see anal warts, and you'll witness a prolapse. Now, prolapse is a little bit distinctive compared to a hemorrhoid. A hemorrhoid, if it's a grade 4, sometimes a grade 3, the prolapse through the is very vascular, whereas a rectum prolapse has less vascularity. Now, if you don't know the difference, it doesn't matter. Anything that's a grade 4 or prolapse from the rectum will be referred, so you can go from there. For a closer look at hemorrhoids, there's 4 grades to it. Grade 1 and 2 you won't know about. The complaints are often discomfort and pain, lumps on palpation itself. So with a digital exam, you'll feel lumps above that donate line. A grade 3 will start obviously above the donate line, but then extend down and sometimes prolapse out, but then come back in. And a grade 4 is out, always. Often has to be surgically removed. When we start looking at discharge, we're actually initially looking at discharge of fluid. Okay, so fecal fluid as opposed to discharge of anything else. Now, the best way to describe these is if the person is continent, so has control of their bowel movements, then pretty much it's caused by a series of the other things that we've talked about. So your anal fistulas, your polynoidal sinus, any STIs, that sort of thing. But can also be caused by certain types of cancers, so often needs investigation. If it's incontinent, then it's often associated with the weakness of those internal sphincters and surrounding muscles. It can be an involvement in neurological or a result of trauma itself. Rectal bleeding is unique, and as we go through our subjective questioning, we'll have a deeper look in how to define the type of bleeding that comes out. But just know that pretty much all of the pain, minus the proctalgia, can cause bleeding, as too can all of the lumps. Now, most of the time when you have bleeding, or the patient has bleeding, people automatically think cancer. Now, unfortunately, it can be cancer, okay, but most of the time it's something else. So you need to have that investigation of what's actually causing it and make sure you don't dismiss it all without a decent consultation. And pruritus itself is just itchy, and that has a huge list of causes, a massive, massive list. We're going from psychological factors like stress and anxiety, even the fear of cancer can cause pruritus, okay, as mean as it is. It can also be an extension of a whole bunch of skin disorders, normal psoriasis, diabetes mellitus, candida can go down there. It can be associated with worms. So if you have a helminth infestation, threadworms, you can get this irritation on the exterior aspect of the anus, diarrhea, constantly wiping it, and then you've got your series of irritations. And in our line of work, it's very commonly caused by chafe. Hot, sweaty environment, really tight clothes, causes chafe between the buttocks. People don't know what's going on, and they end up with this irritation. Okay, let's move on and we'll have a look at the consultation itself. So as always, we start with the event and we find out what reason the patient has for coming to see us. So we always listen to the story, and remember what I said about judgment. Hold all judgment, listen to the facts, and try to figure out what sort of problem the person could be having. From there, we can also look at associated symptoms. Listen to the way the patient describes their complaint. Is it more of a pain, a lump, itchiness? Is there any associated discharge? But also consider all the other general symptoms the patient can have to paint a picture and try to figure out what has actually happened before we move into probing questions, mind the pun, and investigations thereafter. So looking at past history, we really need to know bowel habits. A lot of the disorders that we've spoken about already are a complication or a manifestation of both constipation and diarrhea. So we need to know realistically in the last 72 hours, even up to 5 days, what the patient's bowel habits have been like. We can also look at what sort of activity they've been doing, what sort of physical environment they've been in, what sort of restrictions they've had placed on their bodies as far as clothes and also the ability to maintain hygiene, that sort of thing. And then we can also look at other associated things in their social life, especially if the onset indicates some sort of penetration sexual act. Even if it doesn't, and the symptoms they are describing leads to that, you can also ask tactfully any sexual history associated with anal penetration. And that's both male and female of any sexual orientation. You'll be surprised, or maybe you won't, of what people can get up to. So just ask tactfully in order to gain the understanding and narrow down your differential diagnosis. But that's pretty much it as far as past history goes. We'll move into a little bit more about their social life and their environments when we look at that subjective questioning. Now, depending what the patient has complained of, if it's pain, we need to get a pain profile. So we use PQRST for this as well. So pain on defecation, as mentioned, is very particular for your anal fistulas, but not solely. So ask when the pain happens, what makes it worse, what makes it better, that sort of thing. Find out if it is in fact random, because that makes it very difficult to diagnose. The quality of pain ranges from a burning and itching sensation to a pressure, but it can also be quite high level and debilitating at times. So always ask what sort of quality of pain the patient is feeling. A burning sensation is more associated with hemorrhoids, whereas a high level pain associated with defecation is more associated with your anal fistulas. Radiation is not common, but can happen. So when you're dealing with anal fistulas, it's quite common that the person can't actually tell you where the pain is. It just is isolated to the rectal region and then that's it. But some cases can actually have radiation of that pain running down the back of the leg, similar to a kidney profile, and it can even spread up to the lower back. If you're dealing with your proctalgia, then there's no radiation at all. It is what it is, as to is the same with any of your lumps, your warts, your hemorrhoids. The pain is isolated to a particular area. The severity, as always, is only really used to define how debilitating the pain is. So ask them at rest, ask them at worse, ask them the wave effect of the actual pain, find out how bad it actually is, which will lead to what sort of management you need to do. And duration is key. Certain disorders manifest from acute to chronic based on timeline, and you can also find out how the evolution of the disorder is forming based on how long it's actually been going on. If the pain is more leading to that irritating pain and pruritus, then you can ask specific questions about irritants. Now, there's a huge list of very amazing foods that can cause anal irritation. That's your beer, your caffeine, and your milk. So if the person has started or not used to having those things and then all of a sudden has started having an increased intake, then it can be a contributing factor, as do citrus and tomatoes. Chilies are a very common irritation. If people aren't used to eating chilies, they're not used to the burning sensation thereafter. Therefore, it can come in as a complaint. So keep that in mind. However, the time frame for chilies is much shorter compared to citrus and tomatoes. That can be weeks in manifestation as opposed to 24, 48 hours. Also look at the type of topical agents that they may be using, and that includes deodorants, detergents, powders, new soaps, any tight clothes as we talked about, and even something as simple as using a new toilet paper can also be a cause of your pruritus. From here, you can also look at any interactions with animals, any interaction with farmlands, that sort of thing, in order to lead us down a line of helminth infestation, worms. It can also be associated with overseas travel. When the questioning needs to go down the line of discharge, then we start talking about what exactly is being discharged. Okay, is it just fluid or fecal-based discharge, or is there an element of blood? If there is blood, we need to know colour, we need to know where it's found, and we need to know whether or not it has blood and mucus mixed in. So a general rule of thumb is bright red blood in the toilet, separate from the feces, is your internal hemorrhoids. Okay, so your grade 1 to potentially 3. Any bright red blood on toilet paper, you've got hemorrhoids, fistulas, sometimes pruritus, sometimes anal warts, but that it can be anal cancer as well. So don't dismiss it without further investigation. If you have blood and mucus on the underwear, then you're dealing with grade 3 and 4 hemorrhoids, a prolapsed rectum, or some sort of mucal prolapse itself. But basically, you've got some sort of prolapse happening in the underwear. Blood on the underwear but no mucus, then perianal hematoma that's ruptured, or anal cancer, unfortunately. And then if you've got blood and mucus mixed with the feces, then we start thinking higher. Okay, higher problems like your colorectal cancer, proctitis, that sort of thing. Okay, so when the blood and the mucus is mixed with the feces as opposed to being separate, it's not often a anal rectal disorder. It now becomes a bowel disorder, and that is the same fact when you're dealing with just blood mixed with feces, when you've got malign blood, or when you've got large amounts of blood as well in the absence of trauma. Okay, so they're your general rules of thumb when patients are describing what sort of blood they're finding and where they're finding it. When we finish our subjective investigation, we look at allergies and medication. Apart from the topical irritants we've already spoken about, there's no real link, well, no strong link between allergies, medications, and any disorders. Certain medications can cause anal leakage. Okay, so that can be a leak, but it's a very rare side effect and often not associated with our demographics. So allergies and meds are purely asked in order to help define what sort of treatment we can, what sort of windows we can look into. When we move from subjective investigation into objective, this is where things can get a little bit sensitive with the patient. We always start with vital signs. If the patient has a temperature, or if the patient has signs of compensations due to a loss of blood, that's immediate referral. Okay, a temperature is mostly associated with a perianal abscess, and they need a referral, they need immediate management. Okay, obviously, compensation, blood loss, okay, that's a pretty good bleed, pretty good hemorrhoid. They can get referred from there. As far as inspection goes, an external inspection should always occur. Okay, if you're not mature enough to do an external inspection of an anus, then you're not mature enough to be a clinician. So just consider that. When you're inspecting the area, look at the entire buttocks, obviously for that irritation, the pilonidal area, and the actual inflammation points to denote any abscesses and that sort of thing. Look for irritation around the anus to denote pruritus. Look for any swelling, and then obviously check for any lumps. Get the patient to lie on their side, and then you'll need to gently spread the cheeks. If you're rough, you can actually make the anal fistula more painful and then just get uncomfortable for the patient. So that's your external. As far as a digital exam goes, it's obviously you can do a digital exam. It is part of the investigation, and really an objective investigation isn't complete without a digital exam for a lot of the disorders. But in reality, if you're going to refer this patient onto somebody else, then you're subjecting the patient to 2 digital exams. So if you're isolated and you're the one that's going to be doing the full management for this patient in most of the cases, and you have telecommunication, consultation with MO, all those sorts of things, then yeah, do a digital exam. But don't just do a digital exam because you're curious or because you think you have to, especially when you're leading towards referring it to the next step. Who's going to do another one? Okay, it's not comfortable for the patient So consider them. From there, we can obviously do more investigations. Pathology is a good one you can move on to. So things like your full blood count can tell you about anemia. You can also look for increased levels of eosinophils for worm infestation. You can do MCS or scrapes, or something known as a Scotch tape test, which is literally putting tape on the anus and looking at it under a microscope for any worm evidence, like eggs or dead worms, that sort of thing. So that's a common one to do. A fecal occult blood test is not very common when you're dealing with rectal anal bleeds. Okay, a fecal occult test is better for colorectal problems, so it's often not done in this space. Scopes can be an indication, especially if you're starting to move into those chronic or suspecting cancers. Once you have all the information, you need to make a decision. You need to make a decision on how serious it is. Pruritus caused by irritation because you're in the field, not too serious. Okay, you can definitely manage that. But if it's something that you can't manage in your area, then that needs to become part of the assessment. Do you have all the information, or do you really need further investigation? If that's the case, then refer them to somewhere where they can get that investigation. Look at what their main complaint was and what it was associated with, whether it was pain, discharge, lumps, itchiness, all these things. And remember, if there's any temperature, signs of compensation, or buttock swelling, even isolated redness, then it's immediate referral because you're suspecting an abscess. From there, we move on to our treatment, and this is where education plays a massive role. A diet and bowel habit is huge when you're dealing with anal rectal problems. Most of the disorders we've spoken about are caused by constipation and diarrhea. So if somebody's diet and bowel habits can be improved by easing the strain and the tension that is placed on the evacuation process, then these disorders will be less likely. Okay, the main cause for your perianal hematoma is bearing down too much. So unless somebody's doing a huge amount of deadlifts well beyond their capability, it's mostly caused by really trying to evacuate the bowels with constipation. Okay, so that's the most common cause. Most common cause of pruritus, believe it or not, is hygiene. That's where your tight, sweaty clothes come into play. If people aren't keeping that area clean, then it's a problem. When you're in a dirty environment and it's sweaty and you've got irritation and you're relying purely on toilet paper to clean the area, no showers, then you are more subject to pruritus of the anal area, which causes your irritation. Tell them to avoid trauma, especially during the active aspects of the treatment. Okay, so avoiding trauma, if they engage in sexual activities involving the anus, then educate them on the use of lubricants and tell them to refrain from it whilst they're healing, especially from hemorrhoids or anal fistulas itself. Now, the elephant in the room dictates that we need to talk about the subject of rape. Now, if rape is indicated at any stage during this investigation, then pretty much the objective and subjective questioning line, interrogation or consultation stops, and it goes more into a mental health support consultation. And they need to have a referral to an area where pathology, things like that can be taken, and then further ongoing psychological care can occur. So always keep in the back of your mind that sometimes fistulas and anything associated with trauma can be associated with quite traumatic events. And it's your job as a clinician to navigate that and correctly manage it. Don't dismiss them immediately, but realize that referral is definitely in their future. Moving on to treatment, education, believe it or not, is the main treatment for most of these disorders. You can use topical anesthetics, things like hemorrhoid cream for pruritus. Okay, hemorrhoid cream has a topical anesthetic and a cleaning agent in it, so it's actually quite good for your chafed buttocks as well as your hemorrhoids, so it's not a bad choice in the immediate sense. You've got to be careful sometimes with pruritus, And if they have the ability to clean themselves and get out of that environment, it's better. But if you're in a situation where they cannot leave, which happens, then these topical anesthetics, even soothe cream, can help alleviate a lot of the discomfort. Anal fistulas, yep, you can use the same thing. So pretty much the treatment for it in the immediate sense is removing that pain or that irritation with the topical creams. From there, obviously, the treatments extend well into surgery and management. Sometimes antibiotics, very rarely, because if you're dealing with an abscess, you're evacuating them, and then they're going to get the antibiotics and care that they need. Restrictions, consider the patient's comfort. Consider the patient's hygiene. If a person has hemorrhoids and they're quite significant, they can't really keep clean. If they have a wound in the perianal area, they can't really keep clean in the field. So sometimes that needs to be the consideration of why they're evacuated from the field and why they're giving restrictions in order to manage their condition. You want to refer everything. I've said it a lot, but these are the big red flags. You want to refer all temperatures, all swelling of the buttocks, anything that needs a surgical consultation, anything denoted as a large bleed, or anything that you're looking at just going, it doesn't quite fit. I need more information. I can't do the examination, so they need to go to a new area. Okay, they're the ones that need referral. Okay, so that brings us to the end of the lesson on anorectal disorders. I hope you got something out of it. It is a very difficult consultation to perform. The patient has come in knowing full well how uncomfortable and embarrassing it is for them, so don't make it worse being the clinician. Listen to them, care for them, narrow down what the problem could be with good questioning, detailed questioning, and respectful examination in order to provide the best care you can. But until next time, take care.